Welcome to another episode of Reboot with Dr. Arasi Maran. I am your host, Dr. Arasi Maran. I'm an interventional cardiologist and I practice at the Medical University of South Carolina. However, this podcast initiative is completely separate from my responsibilities as faculty. The point of this podcast is to bring healthcare awareness and evidence-based science to everyone who's interested in rebooting themselves, resetting themselves, looking for a better way to live. Today, I have a very special guest with me, Dr. Tristan Smith. Dr. Tristan Smith is the medical director of the cardiovascular service line and structural heart innovations at the Trinity Health System. He is also the co-chair for Structural Heart Clinical Council at the Common Spirit Health. Welcome, Tristan. So good to have you here.
Thank you very much, Arasi. It's very nice to be here, and thanks for the wonderful work that you've been doing over the years, and now this podcast that you have. I think it's very important and very good. Thank you very much for the invitation.
Thank you. I'm so glad you're here. I think we're going to have a fun conversation. So far in this podcast, we've talked about why is obesity a disease and why it should be considered and treated as a disease, the treatment options, etc. We talked about peripheral arterial disease. We talked about blockages in the blood vessels of the heart. But today I want to actually discuss a very common but ignored issue of disparities in healthcare. How certain population, get whatever they want, access to healthcare, but certain populations don't. And I think you are the right person. You've done so much work on that. So can you, can we just first start about what do you think? What are the unique challenges, especially with related to cardiovascular health and obesity or metabolic syndrome itself?
So, as you know, Arasi, there are disparities that pervade the U.S. health system. And a lot of the disparities have to do with access or lack of access to care. And a lot of it has to do with the economics and socio-cultural background and context in which this care is provided. We do know that these disparities tend to be more prevalent in the South, in the Southeast region, where there's a larger population of African Americans. But there are also disparities within, female versus male, etc. Yes. And there have been multiple studies, and multiple people have used their platforms to highlight the disparities that exist. And I think we've gotten to the point now where we understand a lot of the disparities and where they're coming from, but we don't have any concrete way of dealing with it. I think when we go back to the root cause of the disparities, we have to look to the historical context that have been pervasive over the years. For multiple years and multiple generations. And we also have to look at the policies that have been enacted that impact care in a disparate way. So whatever policies or whatever changes we come up with, knowing what the history is, though the policies have to be different for us to be able to address these disparities head on.
I mean, I think the biggest problem here is that there's a unconscious bias, right? And we are educating everyone about the unconscious bias. I think the term unconscious bias itself is educationable, right? Not many people know that they could be suffering with unconscious bias. What do you think about that?
So we're all biased. And I think the first thing that we need to recognize is that we're all biased. We all have had different lived experiences. And because we've had different lived experiences, it affects our subconscious in very different ways. I have my biases, mm-hmm. right? The important thing for us to do is to understand that we have those biases. And when we do, we can sometimes check ourselves. It doesn't mean that you're a bad person, right? Yeah. If you're biased. We live differently, we think differently, we act differently. And just because we have a different or unconsciously we think in a particular way, does not make us racist, does not make us bigoted, does not make all of these bad words that are thrown out there to stigmatize what we really need to embrace. I think that's where the problem is. Someone saying they have a bias is then looked as something that's bad, when we all know that we have biases. I mean, within the medical context itself, as you know, we talk about bias all the time. We talk about heuristics. We talk about anchoring biases because, someone comes along and they make a diagnosis, and we come along, and if we don't put aside what our colleague had said that this particular patient has, we just go along with it because we're biased in that way, and we just take the path of least resistance. So there is a lot of unconscious bias, and I think we need to speak about unconscious bias or implicit bias as something that's normal, so that people understand that it's normal because they've had a different life context. And then when that's the case, they can then think, well, am I really seeing this from the right perspective? Should I stop, take a step back, and reassess? And I think if we start doing that and we start being open and honest about our fallacies as people and the way we think, I think it'll be better for the whole medical community, and we'll be better able to serve our patients.
Beautifully said, Tristan. It's so emphatic and it's so true to the point, right? I have to say a small story here. I had a patient who's a 39-year-old African-American female with chronic kidney disease. And she was, morbidly obese as well. And she came to the hospital 3 times with chest pain, completely got ignored, finally got a heart cath, had triple vessel disease, went for cabbage, and since cabbage coronary artery bypass surgery, and still kept having chest pain. And everybody ignored her for another year. So she went around for 1.5 years, trying to get this fixed. Then she finally got frustrated and she said, I want to find a female physician who would listen to me and listen to her. And she came and found me. I said, this is really crazy that no one's even done a cardiac CTA or something. And we did a cardiac CTA and all her graphs were done. And then we had to do CT or PCI and things like that. So even though we know we suffer with this bias, it's very difficult to overcome it. Are there any 85 things we can tell ourselves, anything we can tell ourselves when we come across a situation like this? Women get ignored, women of color get ignored, women of color who are also obese get ignored even further. How can we train our brain to think differently?
Well, what I like to say is that we need to have radical transparency. And that radical transparency has to be without and within. We have to be transparent with ourselves. And we always have to consider the opposite. Consider, what if I am wrong, right? And that's the approach I've taken, not just in medicine, but in life and as a leader. Mm-hmm. I'm always thinking, this is what I believe, but what if I am wrong? Mm-hmm. And you then question yourself. Series of questions. If I am wrong, then this would be the case, or that would be the case, or this might happen. And then when you train yourself to keep asking yourself and being radically transparent with yourself, then you start having different perspectives, and you start saying, maybe, just maybe, that person is not lying about having chest pain. Or maybe, just maybe, I am seeing this patient as someone who's non-compliant, as we say, but instead of being non-compliant, that patient does have a significant economic issue that's impacting their ability to get to the appointments, 2, their ability to afford medications, and 3, sometimes there's their ability to sustain life. So when we have that different mindset and we consider other alternatives and we make that a part of our daily routine, then we start to change the way we think. And I think we have to start educating our medical students, our residents,
Hmm.
um, to think that way, because there is this, you know, perception we have, and when we go through medical school, we're everyone who goes through medical school, I mean, are super intelligent. They're there for a reason, and we've built up within us that desire to always be right,
Yeah.
or that is that innate thing in us that when I think about something, I'm 100% right. And sometimes we just have to roll that back a bit and say, what if I'm wrong? What if something else really is happening? And that's where we get insights, and that's where different perspectives come in, and then we course correct, a lot of times.
And I think the same biases exist with patients also, right? In the sense that they don't want to come to the doctors. There's a general mistrust of doctors. They also fear if they come to the doctor is going to throw a bunch of diagnoses, is going to ask them to change their life. There is almost a reluctance to change status quo with their own life, and they don't want to come to a doctor. So how can we mitigate that? That's why I think we see patients in end stages, like when we could have prevented this long time ago, but they have their own implicit bias, unconscious bias, and they don't want to come to us also. What do you think about those situations?
So I think it goes back to what the fundamental premise of being a physician is. And that is about creating a therapeutic relationship with the patient. It is very rare that a patient comes to me for the first time and leaves with a bunch of medicines changed. Right?
Hmm.
It's very rare. What I like to do is to bring them in, sit, chat. I know our reimbursement structure, and the way we have our codes, etc., makes that very difficult. But I have tried as much as possible to make patients as comfortable as they can be when they come to the office, so that we have a chat. We discuss what their goals are, and they get to understand where I'm coming from. And the first thing I say is, hey, I am not a person who would just push pills on you. I like to get to the bottom of what your issue is. And we're going to get through this journey together. And they like that. Patients like having a bit of agency in their treatment plan. And I found that with that agency comes more compliance and comes more responsibility. There are many patients who've come and they were deemed as being difficult patients, right? They come and you realize that they do have legitimate concerns. They do have legitimate fears. Um, Maybe their father or their mother underwent a procedure at some point in time and it didn't go well. So now, although they're having angina, they have a positive stress test, they're afraid to undergo heart catheterization. Um, you would have to invest the time. And unfortunately, more and more, that time that we need to invest in ensuring that therapeutic relationship, not just from a physical standpoint, but also from an emotional standpoint. We're so stretched thin, and the time that we're allotted to really get to the root of problems and meet people where they are in that empathetic way, that time is very short and is
Yes.
getting shorter by the year. So whatever redesign that our healthcare system needs to get to help us get to the root of disparities and help us to get back to patient-centered care must take that into account. We cannot be rushing in and out of patients' rooms, because we will never get there. We will never build trust, and there will never be that connection that we need that's therapeutic.
I mean, sometimes we ask the impossible out of patients, right? See a doctor, see a brand new person for 2 minutes, and yes, sign give me your consent to do a procedure which has a 5 to 8% chance of major complications and things like that. So one of the things I'm trying to take from my business school education into medicine, I'm sure you noted the same thing. how much of communication skills, which is being taught in the business world and MBA schools and etc., and how little that was taught during our medical school or our training or our fellowships, right? It is crazy how that part of us was not actually trained, and they think we should just have it innately.
Yes, and I think that's why I just graduated from Thunderbird School of Global Management with a MGM in International Business and Leadership for the same reason.
Mm-hmm.
That is a part of our education that's missing. That communication aspect. Now, I'm seeing, in medical schools now, you don't even have to be interacting with a fake patient anymore. Now it's just dummies that are there, and you go, and then there's someone asks you a few questions, and you move on. So we're losing that physical and emotional touch and that ability to really communicate. In the business school, they teach you to over communicate, right?
Yeah.
To over communicate, have closed loop communication, always have this closed loop feedback. And in medicine, I think we're just so very open ended, and we're so prescriptive in one directional sort of communication instead of that 360 communication that we need. So I totally agree with you on that.
So we should get it back to our track here. We both got
Oh,
digressed. But this is a
that's
great
true.
conversation. I have to just mention, I'm doing my MBA. I'm in the middle of it at Kellogg right now, and the first few months of code classes and courses, I was getting so angry. I was getting so angry. Why wasn't this taught to us? Why are these business people learning this? We as doctors, this should have been prioritized to us, because we see patients in their most vulnerable moments, right? When
Yep.
nobody comes to see, very rarely do patients come to see us when they are healthy. They come to us when an extremist or something like that. And we are the ones who should have the ability to convince them and build trust with them. And, sometimes we ask a lot out of our patients with very little work from us, apart from,
I
yes, we've spent years in education, but not with communication at all.
100% agree. 100% agree.
So, coming back to the, I feel the root cause, one of the root causes of why American healthcare system, or even internationally, the global healthcare system is burdened with cardiovascular disease or diabetes, and stroke and hypertension and hyperlipidemia, is what we eat. We've forgotten real food. We have forgotten that food is the medicine and exercise is the best antidepressant in the world. And culturally, African Americans and Hispanic community members are high, and Indian, South Asian populations, they are all at high risk for obesity, diabetes, cardiovascular disease. And, we have forgotten food is the biggest contribution of it. And in all these communities, in all these ethnicities, rather, food plays such an integral role, and food is associated with celebration. How do you think we can, change that, or, convince people that food is just fuel, and it does not need to be a therapist and a best friend and a comforter or all of that?
Well, I mean, we all know the best medicine is food, right? And that's a concept that's well known, and it is easy for us to try to get that message across. I mean, it's easy for us to say, "Hey, we need to eat fresh food. We need to use less processed foods, etc." But have you looked at food prices recently? There is a reason why we've moved so swiftly towards processed foods and foods that are unhealthy, because they're cheap.
Yeah.
And when there's a family of seven, one person is working, kids have to go to school, they need transport, they need food. You would gravitate towards what's cheapest so that you can make ends meet. I think where we've gone wrong as a society as a whole is allowing the unfiltered um, processing of foods, which in my opinion is probably the worst strategy. I think if we've been able to, if from a policy standpoint, um, there were more um, attention placed on, okay, making sure that foods aren't that heavily processed, because you go to France, you go to Italy, you go to England. Yes, they're processed foods, but it's not as intensely processed as it is here. You can still find fresh food at reasonable prices. So it is this it is this push and pull that we have between what it is we know that's good versus what is convenient and cheap. And we see again that the business part of it, and that desire to appease shareholders and make sure that you bring value to your shareholders, that in itself is taking precedence over putting out products that are healthy, um, to be consumed. And I think that is a major problem, and I don't see how we can get around that. We can't tell people to eat healthy when the cost is so high,
and the convenience, and it's up in your
and the
face, like,
convenience. Yeah.
I'm sure you saw it in business school of marketing, and how intentionally they place the processed, ultra processed foods right next to the the checkout counter, so we mindlessly buy the unhealthy
Right.
candy and the soda. And I was like, how come none of you guys came up with a plan to make patients more compliant? Let's make them eat more healthy food. We are just fueling. It's like we are chasing our own tails with this whole. One side, we complain about how the healthcare cost is so high. On the other side, we fill the population with crappy food and expect everyone to make the right choice, and you get judged if you don't make the right choice. All the implicit biases which comes with that.
It's unfortunate, and it's it's funny because when you so I'm originally from Grenada. So I'm from Grenada. We have what we have an agricultural based economy, and the raw foods that we export are very cheap, right?
Mhm.
Then they come and they get processed, and they're sent back, and they're expensive. So there is this in my I've always thought in my mind that if you have to refine foods, then the food that is natural should be cheaper, right? Because then it does not have to go through that processing and storing and packaging and all of that. But for some reason, here in the US, our fresh foods are still more expensive than the processed foods, which sort of is sort of mind-boggling, because with the processed foods they add so many things into it that it gets stretched. But the natural law, as I would see it, for food should be that the unprocessed foods should be the cheaper
Portion.
of the alternative. Yeah.
Yeah. And it's sometimes I've had trouble, Tristan, convincing my patient like about weight loss and things like that, especially with the African American community, because culturally they like to be curvaceous and they like to be on the heavier side, and they are very upfront. They'll be like, Dr. Maran, I don't make me skinny. And like, if it was so easy to make you skinny, you wouldn't be here. And there's a cultural bias too. How can I cross that bridge? How can I tell them being skinny or losing weight does not mean you need to lose your identity?
So that's a difficult one. But I think if we message it correctly, being healthy doesn't mean that you have to be super skinny, but it
Yes.
also doesn't mean that you have to be overweight or obese, right? Um, we have to send a message that there is a healthy balance that we can meet. I think a lot or some of the issues, I would I know from from a man's standpoint is that, if you lose weight, then you get skinny, so to speak. But what I would tell them is, yes, you lose weight, but you can lose healthy weight. You can get muscle, right? So you can exercise, you can lift weights, you can do things that keeps your form, and not necessarily, because we have a saying, we don't want to look like, there's a jacket that's just on a hanger, so to speak, right? You don't want to look like the jacket on a hanger, right? Or the hanger on the jacket. You also want to be able to be bulky, but that's a different type of weight. So we just have to get people to understand that there's a healthy weight and there's an unhealthy weight, and there can be an appropriate balance if they're willing to put in the time, the effort, the work, and the dietary modifications that need to be made to make it happen.
It's such a busy life. It's so hard just to even eat healthy food. Now we say eat healthy, make time to exercise. It just seems like we're asking too much, especially in the face of advertising and marketing, and deals in Subways, and deals in Denny's, and $1 meals and things like that. I think it can be very overwhelming as a patient, as a listener of this podcast. I'm sure so many messages are coming across.
It can be daunting, but we have to, again, message it in a way that I don't tell my patients that they need to go to the gym 5 days a week, right? They just need to incorporate exercise or walking in their daily lives. So if you work, like some of my patients, they work at Lowe's, right? I would
Mm-hmm.
say, yes, instead of standing on that little scooter thing and moving around, yeah, it's best if you walk from aisle A to L, okay? And that gives you some mobility. It's good for your joints. It's good for your heart. And then I said, intentionally during the day, instead of just sauntering along, pick up your pace a little bit, right? And just be intentional about it every day. I think, again, our culture is such that we associate exercise with going to the gym, or we associate exercise with having a Peloton or a treadmill in the basement, when there are many activities that we do during the day that can serve as good times for us to exercise. At work, you know, I try to take the stairs, right? And then sometimes I'm very intentional about it. I'm like, I'm going to go up to the fifth floor and I'm going to move very, very quickly, right? Sometimes you're tired, you do it slowly, but it incorporates that exercise into the day, and therefore makes it easier to accomplish your goals, instead of, being task oriented. So, exercise shouldn't be a task. It should be a process that's incorporated into daily life.
One of the things I kind of tell people is, have you ever thought that you always brush your teeth every day? If you have to think about it, you brush your teeth every day and twice a day sometimes. And how come that does not seem like a big task? And I can tell them exercise should be like that. It should be so incorporated into your life that you don't think of it as a task at all, and you just get on with it. And I think some of the parts of depression coming from being alone, or getting old, and your spouse is gone, etc., maybe getting a walking buddy, or joining an exercise community, or a community of walkers or something in the neighborhood, that could be a good way to socialize, make new friends, and it's incorporated into your life and not a task, as you said.
I've seen, and I've had so many patients who, they've joined Silver Sneakers, and they are just so over the moon because they go and they get to walk and they meet people and friends, and they make new friends. And that is a really good way of getting exercise in, especially if you're over 65, you're in that Medicare population.
Mhm.
It's fantastic for that. So I agree with you. Just getting out and about, that definitely helps mentally as well as physically.
Absolutely. I mean, the name of this podcast is Reboot, and that's the whole point, that there's no age or there's no barrier but yourself to reboot your life and reboot your health. And but you have to make that first step, getting out, where putting up, tying those shoes and walking out, or and it can be hard and daunting. And I've heard a lot of people say how they get intimidated when they go to the gyms because they all see all these gym bodies, like making noises and all of that. And I said, and I tell him, you don't need to. You can work out at home. You can walk around the block. No one's stopping you there.
Yeah, it's all individualized, and everyone need to have their own goals. They need to set their own plans, and not get sidetracked by what X, Y, or Z are doing, because your health is your individual health, and that's your individual wealth. It does not depend on anyone else. So you should not be looking to anyone else for clues or cues for what you should do. Right? You set your plan and you go ahead and you do it.
Yeah, and I sometimes I find it very funny when I mean, a lot of our patients are older and wiser, right? They're like in the 70s. They've lived through things that we've never seen, and they'll be like, "What is the best diet?" I'm like, "I know, you know, at the bottom of your heart, all the bad things you're eating and all the good
Yeah.
things you can eat. You don't need me to come and tell you what you should and shouldn't be eating." You know.
Yeah, the diet is definitely something that, yeah, that's a question I get a lot. And honestly, I just tell them I do not ascribe to any particular diet. I'm not one to tell you to do Atkins diet or keto diet or any kind of diet,
Yeah.
because there's so many diets out there, that it would just have my head spinning to figure out which one is the right one. I think portion control is very important, and just having a balanced meal, right? Balanced meal, portion control. That's all I prescribe to my patients. I don't get into the intricacies of different types of diets, etc., because it confuses them, and it makes it so much more difficult for them to adhere to any kind of dietary process that they would want to change. That's just my personal take.
True, true, true. I think, there's always, but the problem is sometimes they want specifics. I had one patient who came to me, I mean, in a 6-month follow up and lost a lot of weight. I was like, what happened to you? Is this intentional or unintentional? He's like, no, 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 it's very intentional. I stopped 3 S's. I'm like, you stopped 3 S, like alphabet. He said, yes, sweets, snacks, and second helpings. I said, okay, there you go. That's a good
Oh,
mantra.
that's a good, we can call it S cube,
Yes.
S3. That's a good slogan.
I told him, I said, this is, and I actually used it to a bunch of patients after that, and they all laughed at it. And I said, when you're going for the second helping, can you just pause and see, do you
Yeah.
really need the second helping, or can you just get past without it?
That's great. You see, patients teach us a lot too, right?
Oh yeah, this is a
Yeah,
mutual learning process. It's
yeah,
never a
yeah,
one-way street. Absolutely,
yeah.
absolutely. So for our listeners, what would be, give us a success story of where you actually saw a disparity, or a reluctant patient who did not want to seek healthcare because of what or their previous experiences. And my story of this 39-year-old female. Did you have, I'm sure you have a lot of stories. Can you share something like that?
Yeah. So there are patients who you know they have pathologies, and they go to physicians, and physicians tell them, hey, you're too old, or nothing can be done for you. So I had a patient, who was 98. um, I had seen his wife before, so I knew what he looked like. He fought in, I think, World War II or in Vietnam. He was a legitimate vet, right? Combat,
Mhm.
and I had seen his wife, and unfortunately, she had died a few years prior. And then he showed up in my office, and he's like, I'm short of breath, and I have aortic stenosis, and I've gone to three different hospitals, and they said that I'm too old. I'm 98. But I knew him from before, and I said, "Hey, I know you well. You. When I saw you the first time I saw him, he was in his early 90s, and I'm like, he looks like he's 70, right? He looks like really, really buff. He had strong muscles, and I'm like, well, I know you. I know when you were coming with your wife. Let me see. Let's do the workup. So we did the workup, and found that he was an appropriate candidate for TAVR. So we went ahead and we did TAVR. He
So,
was
Tristan, I'm just
98.
going to stop you. Let just
Hmm.
to explain a couple of medical terms we use here. Aortic
Okay.
stenosis, aorta is the big valve in your heart, and when that gets really blocked, the entire body does not get adequate blood flow, so that has to be treated. And TAVR is a percutaneous replacement of the aortic valve instead of open heart surgery. Sorry, please continue.
Yes. So thank you for clarifying that. Um, so I spoke to him. I said, yes, your aortic valve is narrow, and yes, I think we can fix your aortic valve with the transcatheter aortic valve. And he's like, I've had a good life. I've always been okay. But I'm now short of breath. I'm filling up with fluid in my lungs. I would want to have something done. So we went ahead and we did the transcatheter aortic valve, and he's now 101, and he's doing great. He's doing fantastic. So sometimes we have this ageist
Hmm.
uh, concept without just looking at the age and saying, okay, this person is too old. He's had 3 years of great life. He was on the Smucker's jar when he got to 100 years old. He was on the Smucker's jar with his face on there, and he's happy. His son is happy, and that shows us that sometimes without giving people the benefit of the doubt, without going through the process and objectively analyzing what we're seeing, we just make snap judgments based on either age or race or gender. And people who can benefit from therapies are then pushed aside without having it, and they're just left to suffer.
I mean, this is such a great example, right? There are so many 90-year-olds. My oldest patient is a 94-year-old where I did a complex intervention in the heart only because she was extremely active. She was taking care of her 96-year-old husband. Age is just a number for her. The 90, that age of, nanogenarian does not matter. And I think that's what we all should aim for. And that's what I want. That's the message I want to give to my listeners here, that age is a number. There's always time to reboot and reset yourself and get into a habit of exercising and a habit of eating well instead of thinking of diet and exercise with a start date and a stop date. That doesn't work at all.
Oh yes, and don't get this patient I'm talking about. Don't get him started on diet, because he would just go into how the food is horrible and how good food used to be back in the day. So he's very he would be a good one to give us a lecture on eating healthy.
Absolutely. I mean, he survived to 94. I mean, I'm sure he did that because he did
Yeah,
a lot of things right.
he did. He did.
So, if I have to, we're kind of coming to our end of our time here. Thank you so much. But what would be your closing thoughts? To patients who are currently experiencing different conditions, health conditions, but who are afraid to go to a doctor because of their own implicit biases, and patients who are reluctant, or healthy people who are reluctant to get up and change their life or take control of their life.
Well, for those who are reluctant to take control of their lives, I would say there is no better day than today, right? When we It might seem like it's hard today to change your mindset and change, what you do, what you eat, and how you go about your daily lives. But by starting today, you're going to get more benefits 2 years from now, 5 years from now, 10 years from now. The longer you put it off, the less benefits you're going to get in the long term. And I want us to think about this just the same way you think about your retirement accounts.
Mm-hmm.
And when you're working and you put aside some money in your 401k, or you look forward to getting your checks from Medicare, these are all investments that you made when you were younger, that then you get the returns when you're older. So it doesn't matter what you feel like. Anything you do today from a health standpoint, from exercise to diet to looking after your mental health and well-being, socializing more with family and friends, etc., is going to pay off in the long run. There is this beautiful interplay of the mind and body and soul and spirit that we need to cultivate, not just one aspect of cultivation and leaving the others behind. We need a holistic approach to health. We need, yes, we need our physicians. We need specialist doctors like Dr. Arasi here, who's phenomenal and great. But we also need family. We need friends. We need to be happy. We need to look after our social and emotional well-being. And exercise is one of the great ways of doing that. It 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 ticks all the boxes, right? It helps the body, it helps the mind, and many times when you exercise, you socialize, etc. So for those people, I would say today is the day. It is never too late. It doesn't matter what sickness or illness or ailment you have. Any little bit of exercise helps. Diet helps. And for those who don't like going to the doctors, we hear you. We know that, especially for underserved minorities, that there has been historic discrimination against you. We're here to tell you that things have changed, and we are changing, right? The medical profession as a whole has been changing. I love to see what the American College of Cardiology is doing. I love to see what the Society of Cardiovascular Angiography and Interventions are doing. And I love to see what the American College of Physicians are doing, trying to raise awareness and letting all of the physicians know that we have to do a better job at communicating what it is we want or what it is treatment therapies are for our patients, and make them feel comfortable in knowing that when they come to us, when you as a patient come to us, we have your best interest at heart. We will not do everything perfect all the time, but I
Unfortunately,
have
we are
I
humans.
have that great sense of relief now, knowing and listening to the conversations that's out there about how we can change this landscape, how we can change the paradigm of health going forward, because we've done an abysmal job, right? We've done an abysmal job. There's a study from Carabello, I think it was in JAMA 2023, that showed that from 1999 to 2020, there were 1.6 million excess deaths of African Americans in the US,
Oh,
right? That translates to 800 million years of life, right?
hmm.
So it tells us that we have been doing something wrong. But I'm happy that our policymakers have begun to listen to the plight of the underserved communities. I do think that the societies that we belong to, with voices like yours and others, are moving in the right direction to make sure that we're able to close the gap. I don't expect it to disappear in 1 year or 5 years or even 10 years, but we need to have, and we do have, a strategic plan to get there. So I want to tell all your patients who are listening to this podcast to have some faith, right? You've been heard. We are working on policies and plans to make things better, and you can trust us because we have your best interests at heart.
Fantastic. You've very well said, Tristan. Seriously, that was very beautifully put. And it's a heartwarming. Yes, we've been bad, and we are working on, as you said earlier, radical transparency on how we are treating our patients. And it's a work in progress, but a lot of work has been put. Everyone is aware of the issues right now. So once again, thank you, Tristan, for taking time and coming on. And this concludes this podcast. Thank you all for joining. And if you have any question, please feel free to connect with us. Tristan, I will put your contact information on my show notes if you ever want to reach out to Dr. Smith as a patient.
Sure. Thank you very much.
Thank you. Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.